How does it work?
You all set? You prefer the podium mic or the lapel mic?
I guess I'm not going to be able to wander too much. So
Okay, so the podium it is?
Yeah.
Okay. All right. You're all set.
and will slides appear?
Once I get you get the PowerPoint in there.
So
No one has given.
no one's given it to you, Jordan?
Yes.
PowerPoint?
Oh, I have it on my computer. Do you have it on your flash drive still? Or?
Oh, okay, I can do that. Oh, I thought you were doing. Okay.
Yes, sir. We went off to I'll start the introduction while we're getting set up.
Sounds
That's
good.
okay.
Okay.
And that way we can kind of be efficient time-wise.
Alrighty.
Good.
PC or Mac?
Good afternoon and welcome to Grand Rounds. First, I want to acknowledge a new colleague here at the University of Illinois, Dr. Michelle Mariscalco, who's the former dean of the Champaign-Urbana campus, who's recently moved to work with the VPHA on health systems design issues. And she's already proved to be just really helpful to us, to me, in helping us think about our clinical and other programs. And we're looking forward to more interactions with her, and just want to acknowledge her presence and welcome. It's a great pleasure to introduce Dr. Jeffrey Buckhalter, who is uniquely qualified to give us a clinically oriented update in sudden and unexpected death and epilepsy. But before I offer a few highlights of his training, experience, and other contributions, I'd like to extend another invitation to faculty. There'll be a reception immediately following Grand Rounds. Please make your way across the hall to room 224. This will be a great chance to actually talk to Dr. Buckhalter a little bit further and kind of to discuss the topics in this particular presentation, but also his work in informatics, which I'll share a little bit with you further in this introduction. After earning both his MD and PhD in the Department of Neuroscience at the University of California, Los Angeles School of Medicine, he was an intern and resident in pediatrics at the UCLA Medical Center. Then he changed coast and went all the way from California to Boston, and he did a residency in neurology, which then completed Harvard Neurological Training Program in Boston. Other trainings has included cellular electrophysiology, clinical electrophysiology, medical and biomedical informatics, and health systems delivery research. And in particular, this is really important because we're discussing the possibility that how he could help us further in the area of informatics. This is a major area of expertise that he's developed, and I think would really potentially enhance our work as a health system. And so we're really grateful that he's come to visit us, to visit neurology and pediatrics, and discuss lots of possibilities for collaboration. He's a professor of pediatrics and clinical neurosciences at the University of Calgary Faculty of Medicine. His administrative positions at Calgary include the Comprehensive Children's Epilepsy Center, the Pediatric Neurology Outpatient Clinic, and the Quality Assurance and Outcomes Research section of Pediatric Neurology. He's also a member of the Alberta Children's Hospital Ambulatory Care Committee and several other important committees related to really guiding and organizing that health system. You know, with a distinguished career like this introduction could go on for a long time. So I'm going to say that he is the author of many publications. He's a really internationally known expert in medical informatics, and we're really thrilled to have him here and to talk about a really clinically oriented topic. I think one of the things that with Sab and I learned in going to dinner last night is that he has very wide-ranging interests. He's kept his roots in clinical neurology while he's developed these more complex health system design issues in informatics. So it's a real pleasure to welcome you here today, Jeff. We're looking forward to hearing your talk. Thank you.
I just wanted to thank Dr. Van Voorhees for a very kind introduction and hosting my visit. I guess my CV could be said as, ADHD isn't always a bad thing. Okay?
Yeah, perfect.
Want to do this?
Yes.
Okay. And that's not my talk.
When he's ready, I'll put it.
Yeah.
Just trying to make sure he's got what he needs.
Let's see, where... Where is my drive? Let's see.
Is that the correct one? I see you have multiple ones.
Even my flash drives have ADHD. Okay.
Got it. There you go. Okay, you all set?
I think so.
All right.
We're up. Okay. Let's see. Can I do
Slideshow at the bottom.
Just a review.
Think you want to go slideshow at the bottom?
Here.
There you go.
Close enough. Okay, so wanted to talk about sudden unexpected death in epilepsy today, and do it in a clinically oriented fashion. I have no disclosures which are relevant to this presentation. I didn't quite know how to introduce this topic, because when you've been doing something for a number of years, you think it's all so fascinating, and you have 200 slides, and how are you going to do that in 45 minutes or so? The thought behind this slide, and this was a survey of US and Canadian neurologists in 2014 by Elizabeth Donner at SickKids in Toronto, and it basically asked the question, how often do you discuss SUDEP? What do you know about SUDEP? And what I would direct your attention to is down here. This is less respondents, less than 100 patients with epilepsy per year, and less than 30% of neurologists, including pediatric neurologists, actually discuss the topic. And so my thinking was that if less than 30% of pediatric neurologists discuss the topic, the number of pediatricians that discuss the topic was somewhat less. So what I've opted to do is to try and give you an overview of the field without banging too heavily on the science, just so that you know that it exists. And these are the learning objectives for the next few minutes. But if I could have you learn one thing and then maybe go to the reception next, would be the knowledge that epilepsy is a life-threatening disease. Children and adults die from seizures suddenly in their sleep without any warning. And that is very contrary to what I was brought up with. Part of it's political, and the whole move in family organizations called Living Well with Epilepsy. So if you're living well with epilepsy, what's the big deal? That's incorrect. And the big takeaway from today is that when you see children with epilepsy who are having ongoing seizures, please do not tell them that they could, that everything's going to be fine, they're going to grow out of it. In fact, they can die. This is sort of a depressing talk, by the way, so I'm sorry, but it's about death, and what are you going to do? I want to start it with a very human story, and this is Danny. And we'll come back to Danny in the end. He, 4 years of age, started seizures at 2 years of age, had a total of 4 convulsive seizures, tonic-clonic seizures, over 2 years, all during sleep. He died in his sleep 4 days after seeing his neurologist, who told him, who told his family that he was doing pretty good, not so bad. And I know this because I know the family. His parents never heard about the possibility of SUDEP before, and we will come back to that as part of our charge and our role. And the last part, please go and enjoy your life, Danny did. Danny was from the Chicago area, and this has had impact in your part of the country. So, like most other things in medicine, death in epilepsy is not a new topic. And so this was an article from 1868 in Lancet, and basically it talked about people with seizures and epilepsy that somehow would not reappear from their homes or institutions. They died. But despite the fact that this is very well described in 1868, we sort of forgot about it. And it didn't become a hot topic until about 10, 15 years ago. So now what I want to do is sort of take you through the major topic areas that involve sudden unexpected death in epilepsy, with the hope that you will pass this on to your families. There's a lot of stuff here. I've provided Jordan and Dr. Van Voorhees' office with a PDF of the talk, so you'll have the references should you so desire. So SUDEP, defined as a sudden unexpected non-traumatic death in a person with epilepsy without post-mortem examination evidence of structural or toxicological cause of death. And that definition emerged in 1997 from two separate groups who were interested. And like a lot of what we do, we stratify: definite, with an autopsy, no other cause; probable, no autopsy, no other cause; possible, alternative cause of death, clinical data are lacking. And so that was 1997. As the topic attracted a lot of interest in grant funding, serious epidemiologists became involved and said that definition really isn't good enough. So a group of experts got together in 2012 and provided a much more granular definition of the different ways in which SUDEP can be defined. And so I just want to put that up as a reference for you. It was actually a nice paper, because what they did is give examples, cases at the end of the paper to say, how would you classify these? And so there's a more modern definition of SUDEP out there. As a sidebar, as it turns out, the epilepsy community didn't invite important people to the dinner, to our group. Who didn't we invite? Medical examiners, the people that actually certify death. And that's been correct in the last couple of years, but they again have a different definition. So just to be aware of that. Now, the overview is that, population-based, people with epilepsy have 2 to 3 times an increased risk of death, common in children, and there's been a whole bunch of potential risk factors that have been identified. And this is a smaller list than the one that existed 5 years previously. And we will talk about very shortly what are the key risk factors that you need to know about in the office. So the context is, how do people die with epilepsy? And in my mind, as a resident and fellow and faculty member, in my mind, I thought that most people died over here from infections, predominantly aspiration, predominantly in the setting of seizures, status epilepticus. And, I wasn't too far off, about 20%, with these other things being on the list. I personally had no idea that SUDEP was even on the list. So it was a big wake-up call for me about a decade ago. And status, which we think of frequently, isn't such a big issue. Now, when this hit the press about a decade ago, there were all kinds of estimates as to how many people died every year. And for a number of years, the number was 50,000. That was on CDC site and epilepsy sites. It was wildly incorrect. And so the real number is at least 2,640. It is an underestimate because of ascertainment due to where we get most of our mortality statistics is from coroner's reports or medical examiner's reports, and these aren't reflected here. So it's more than 2,600. It's probably less than 10,000. What is the impact of SUDEP? So when one looks across all neurologic diseases and uses the metric of potential years of life lost from a disorder, stroke is not surprising because stroke is very common, affects predominantly an older population, although we know it's become a big issue in neonatology and pediatrics, new strokes, but the majority are in older adults, so lots of potential years of life lost. The surprise was that SUDEP is number 2. And the reason you'll see in a slide or so is because it affects a younger population, so there's a lot of years lost. And again, this was news to the neurologic community. So now let's move from sort of the context and impact to a brief review of the epidemiology. This is a favorite slide from Torborn Thompson, Sweden, in 2008. So on the x-axis are the references, and on the y-axis are the number of SUDEP cases per 1,000 patient years. And so we start over here, the lowest numbers. If you look at population-based incidence cohorts, it's less than 2. And then as you go up, so here now we have prevalence cohorts, and then we get to epilepsy clinics, and then we get to refractory epilepsy populations, and over here, epilepsy surgery candidates. So, this is a tremendous case of ascertainment bias. My world is over here, your world is over here. But that doesn't mean it doesn't exist, and at the very least, we need to provide accurate information to our families. This is a slide from 1975. The shape of it is in general true, but 2 points. The first is that this is a gross underestimate in the small children age group. It's not 0. It's not 0, and if you've lost a child to epilepsy, it's 100%. Over here at 60 plus, it's actually a bigger bar because the way that forensic pathologists classify cases, sign them out, is if you're over 60 and you die and you have some coronary artery disease, unless there's something big, it's going to be signed out as coronary artery disease and not SUDEP. So at both ends of the spectrum, these are underestimates. This is another compilation of incidence cohorts, and what I wanted to point out to you is, number 1, children are still low, so the likelihood of dying with epilepsy in childhood is low, but not 0. And over here, patients with mental retardation. Just having that comorbidity ups you significantly. Again, a significant part of the pediatric population. Now, how do we break this down further? Because there's been a lot of misthinking about it, and we have some data. This is a paper originally published by Ann Berg, who's one of the more prominent neuroepidemiologists and epilepsy expert, spends part of her work year at Lurie Children's. And so she published this paper looking at about 2,200 deaths. Seizure-related, 70% were non-epilepsy. Of these, 70% were pneumonia, 30% were epilepsy. The majority of those were SUDEP. Non-natural, 7% of the total. So let's break it down. This is a paper that's available online. Elizabeth Donner is the first author, and it's sort of a compilation of a symposium that we did last year. And so if you want one place where it's written pretty nicely for the overview of SUDEP, I think Elizabeth's paper is the most modern out there, January 2017. We look at cause of death in children with epilepsy, all deaths, Okay, epilepsy-related status, aspiration, complication of treatment, non-epilepsy-related underlying disorder, non-natural suicide, homicide. And these are the big series in the literature. As we see in each of these series, the big player for death, for non-epilepsy related, is pneumonia. Next to it are underlying metabolic and neurodegenerative conditions. So the underlying disorder, which is true in all really, etiology series. So that's non-epilepsy related. Epilepsy related deaths, now the big bars are SUDEP. And the smaller turquoise blue bars are status, and here we have aspiration. So you can break it down that way, and so as my wife would say to me, Jeff, why are you telling me that again? I already heard it. I tend to be redundant about important things far after the need. SUDEP is a big player in pediatric epilepsy. Now, I want to bring to your attention one other study, and this was sort of unique. This was done in Finland. It's a 40-year follow-up study. Wow. Yeah. That was exactly the word that I said when I saw the paper initially in the New England Journal. It was prospective, 40 years, population-based. You ain't gonna see this again. And they followed 245 individuals who had childhood onset epilepsy who died, not died in childhood, but subsequently died. But, we're the ones on the front end who are talking to them. What were the results? Well, the rate of death was 3 times greater than the general population. There's a 7% lifetime risk of SUDEP. And you got to remember that although 7% is a small number in the numerator, the denominator of childhood epilepsy is huge. So this is a lot of folks. 48% were not in remission, which means active seizures, which means when you see a child who has ongoing seizures like Danny, he's at risk or she's at risk. And if they have an etiology, i.e. symptomatic, they're at greater risk. So, really it's just been in the last decade or so where the risk factors have come into pretty bright relief. When the number of cases that was related to epilepsy, which was 55% of the total number of deaths, SUDEP was number 1. And so, in the world of science, what one is getting is convergence from a number of countries, a number of times, a number of reports, a number of populations. The answer is the same. Now, what are the mechanisms? And this is the part where I'm particularly weak, so I will go particularly fast. So the first question, if you're going to play hard science, what's the evidence that's actually related to seizures, and it's just not another phenomena. And so a variety of reports, a terminal seizure usually occurs and is the ultimate cause of death in a couple of papers. Clinical observations of witness SUDEP or near SUDEP. Seizures proceed up to 90% of witness cases. Autopsy reveals immunohistochemical evidence of a recent seizure. So it's probably the seizure. What about people with epilepsy and seizures? So when this hit the literature about a decade ago, there was all of these risk factors. Remember, male gender, age, medications, and in particular one medication, Lamictal, seemed to emerge as a correlate of SUDEP. And of course that, made us all, it was a kind of big kerfluffle, because you have a lot of kids and adults on Lamictal. And so Dale Hestorfer, who's a very prominent neuroepidemiologist at Columbia, did a review of all of the published cases. And what she found, and it still stands, analysis of individual anti-epileptic drugs, number of AEDs, adjusting for GTC frequency, revealed no increased risk with AEDs as monotherapy, polytherapy, or total numbers, while GTC frequency remains strongly associated with an increased risk of SUDEP, generalized tonic-clonic seizures. This was preceded by 2 papers that I'll want to draw your attention to for a very specific reason. So if the reference population is 1.0, if you have 3 generalized tonic-clonic seizures in a year, 3 to 12, your risk is almost 4 times the reference. So, and over here, if it's 1 to 3, 2 times the reference, and when you get above 3, it's 8 times the risk. This changed my thinking and my speaking to families, saying, gee, if you went from 20 seizures a year to 3 a year, that's pretty darn good. But your risk is still 4 to 8 times of having no seizures. So 0 seizures is our goal for a very, very, not just lifestyle reasons, for mortality. This slide is put in here to remind me to tell you about the other major risk factors. About 80% of SUDEP deaths occur during sleep. And the whole relationship between sleep and epilepsy is now very, very hot. CURE, Citizens United for Research in Epilepsy, based in Chicago, has made a major funding effort to explore this 2016. And what this tells us, it's not just all of sleep. When you look at the number of cases that died, it's between 4 and 8 a.m. is the big player. And those who died during sleep were more likely to have a history of nocturnal seizures than those who died while they're awake. So now we have generalized tonic-clonic seizures and seizures occurring during sleep. You can't be a pediatric neurologist without looking at differences between adults and kids. And I won't belabor this point, but just to say that, why are there more deaths in adults than children? Well, there are some differences. The total red bar is adults. The total duration of seizures is greater than adults. Recovery time is longer in adults. Postictal generalized EEG suppression, which I'll tell you about in a second, is more common in adults. It's a risk factor. And tonic seizures are more common in adults than children. And just to give away the punchline, it's probably the tonic component of the tonic-clonic seizure that's associated with death. So in taking your history, I used to be sort of loose about it. I'm not anymore. Not Grand Mal, not GTC. Are they shaking? Are they stiffening? Either or both. It makes a difference in how frequently they die. Now, pathophysiology. We at the American Epilepsy Society, we have these ongoing conversations. The people that are it's the lungs, that's what fails, that's what kills you. The heart people say, oh no, it's the heart that stops beating and that's what kills you. And the brain folks say, no, it's really the brain that initiates the whole thing and that's what kills you. Like most things in science, when you have all these ideas, it's probably all of them in different populations. This is a study that tried to address that. It's called the Mortimus study, and that's an acronym that stands for something that I always forget about. But it was mainly a European study, some US sites, that looked at deaths in epilepsy monitoring units and looked at those deaths where the heart rate and the respiratory rate could be sort of measured. And this was, it was a terrible observational study, and yet it's the best one in the literature, and in many ways gives an answer. The bottom line is that breathing stops in all cases before the heart stops. So at least in monitored cases in epilepsy monitoring units, the respirations, apnea occurs before the heart. And this is all the patients that died. This is just an example of, here's the respiratory rate, stops for the heart, respiratory rate, apnea occurs before heart rate stops. So breathing's pretty important, pulmonologists win. And one of the complications in the literature is just because you record something in the EMU doesn't mean it actually is a cause of death. And so there's a robust literature looking at respiratory changes that accompany seizures. It was only the Mortimer study that said, yeah, it's probably linked to death. This is respiratory changes. This is a article I'm putting here for you, geneticists, folks. And of course, there's a huge body of literature looking at the genotype of folks that died to see if there can be any discerned risk factors. And I'll talk about that a little bit just in a slide or so. And of course, there are animal models of SUDEP, some of which make a lot of sense, some of which don't. But if you're scientifically oriented, ultimately our molecular answers come from the lab. Now, this is one study that I put in just because I thought is interesting. An exome-based analysis of cardiac arrhythmia, respiratory control, and epilepsy genes in sudden unexpected death in epilepsy. So these were 61 SUDEP cases, categorized as definite, probable, and looking for de novo mutations. So what did they find? We identified mutations previously reported as pathogenic in 46% of cases, which is pretty high. Now there's all kinds of ascertainment bias because of what the groups were looking for and how the brains are collected and all that sort of thing. But nonetheless, you got to pay attention. And a number of these were long QT syndrome of various kinds. Some cases had pathogenic variants in dominant epilepsy genes. What does that mean? SCN1A and the potassium channel genes. So, in terms of stratifying folks in the office, which we don't quite do yet, one could say that if one had an SCN1A mutation, you're at particular risk for dying for SUDEP. But those of you that know pediatric epilepsy know that that's Dravet syndrome, named after Charlotte Dravet, and yes, those children have an extremely high rate of SUDEP. So there's likely to be a genetic basis. Now, I mentioned this before. This falls under the category of biomarkers. Is there any marker in life that predicts death? And this is a phenomenon called post-ictal generalized EEG suppression. So there's a burst of activity and then things get flat. So the EEG is suppressed. And you may certainly not remember from a previous slide that this occurs after seizures more commonly in adults than children. So this is just to remind me that in children there's a fairly robust literature of autonomic changes with seizures, but that it correlates with EEG suppression. So what we're doing here is linking things together. And this is one paper from Rainier Surgis that said, gee, there's 30 times the risk of SUDEP if post-ictal suppression is greater than 60 seconds. For some, I was about to say for an old guy, this is very exciting, but I'm not going to say that. For someone that's been in the field for a long time, to see all this brand new information just in the last, 7-8 years is pretty exciting. We went from 0 to something you can actually start to look at clinically. So PGES, and duration. Okay, so this was a paper that looked at seizure type over here and its correlation with PGES. So type 1 is a tonic seizure, and look at the degree of significance with PGES, not clonic seizures. You know, who is to say that there was going to be a difference? There seems to be a difference. So it's tonic seizures that are associated with this EEG flattening. And then we look at early administration of oxygen, and did it make a difference? And the answer seems to be yes in abating PGES. This has profound clinical importance, because when families ask for oxygen in the office, do we write that script? It's resource intensive. Is it worthwhile? And so my practice has changed. If I've documented PGES occurring with tonic seizures lasting more than 30 seconds, I write it. That's not the majority of kids, but it's some. And then there are the folks that believe that the heart's important. And of course it is important, different in kids and adults, and probably this will be sorted out by genotype. So what you're getting is heterogeneity of a population. And so the answer that you might want to give in the office if this comes up is, what causes SUDEP? Many things. And you'll be right. And of course there are pathways involved in proposed pathophysiology, and depending on where you think things are coming from, this is where you fit into the diagram. Again, part of the slide set for your reference.
Can I ask you a question? Because this is a nice interface with
Sure.
informatics and some conversation about last night. It seems like this space of personalized medicine, and actually some of these syndromes or diseases which we have lumped together based on large sort of just generic observations of patients and things like radiographs are actually extremely heterogeneous, and there are actually multiple pathways that work. And it seems like almost any disease process we're thinking about now has these many complex pathways based on minor genetic variations. And I'm wondering if you have any thoughts of what it will be like to be a physician in 15 years and be sorting through this, because they could be people could be receiving extremely specific diagnoses and treatments,
So,
not to derail your whole talk.
no. I think so. I've always been a science fiction buff, and the lesson that we learn from science fiction is that, all of those episodes about a creature becoming immortal never works out well for that creature. That said, I don't want 15 years. I want 100 years. I would love to see what this space looks like in 100 years, because I think the way, obviously, that we think about the nervous system and the way genetics and environmental influences affect our phenotypes is going to be entirely different. So that's the sort of the macro answer. The micro answer is that I think we're going to know a lot of these things. And the way that we're going to know a lot of these things, now, since you asked, putting on the informatics hat, use the word granular. I think it's important in our medical records to collect as much important information as possible, because computationally we can now look at outcomes and risk factors in a way that provides stratification. And before coming out here, I was looking at, this is really boring, I know, the conversion from ICD-9 to ICD-10. And that's important for health research, because you have this huge body of ICD-9 diagnoses, and now we're going to 10, and so how do you bring that across? The technology that originally came from genetics, you now see in a whole variety of complex topics in medicine, including what information is gained or lost in that transition. So my guess is in 15 years, we'll be able to sit down, the electronic health record will at last be useful, and we'll pull up all of these individual pieces of information, and in a probabilistic fashion, we'll say, gee, what's the risk of this child dying from SUDEP? And based on cause, what can we do about it? Which is a nice transition to this slide. So now, prevention. What can we do about it prior to 15 years from now or 100 years from now? And this is the list of potential opportunities to intervene. This is a particularly frightening study that came out in 2011. And what it did was it looked at the control groups for anti-epileptic drug trials. So if you were in the placebo arm of an anti-epileptic drug trial, what is the likelihood of dying from a seizure compared to getting active drug? And the answer down here underlined is there's more than 7 times the risk of dying compared with placebo, which casts light on the whole nature of doing placebo-controlled trials in epilepsy. So this is the folks that got medicine versus the folks that didn't. This is sort of a wowie kind of didn't expect this to happen. So take your medicine. What about epilepsy surgery? This was a study from 1999, Mike Sperling, Philadelphia, looked at 393 epilepsy surgery patients. 6 of 194 who continued to have seizures died. 0 of 199 who had successful surgery did not. So that was the first signal in the system, 99. They did it again in 2016 and basically got the same answer. So if you're seizure-free, the likelihood of dying is way less after epilepsy surgery. If you have if you have greater than 2 tonic-clonic seizures per year, 2 or less, it decreases mortality. So simple answer, having fewer seizures is a good thing. And again, in the office, when we see patients, when you see patients, if they're having tonic-clonic seizures at night, and they haven't been controlled by medication, they need to be epilepsy surgery candidates. I'm not saying they go to the OR, but you gotta think about it and refer them. This still hasn't been published in full paper format. This is vagus nerve stimulator as a treatment for epilepsy, the implantable device which stimulates the brain all by itself. And what this shows is SUDEP in years after VNS placement, and it goes down. So VNS placement is another opportunity to intervene. Now here's a sticky one. Observation. These are the 2 studies in the literature, both of which suggested that if someone is in the room that can resuscitate or call for help, and a child is or an adult is having a tonic-clonic seizure, the risk of dying is less. Again, major impact for those of you that remember apnea monitors and SIDS, which was a disaster. You know, we all said, oh my goodness, what are we going to do about this? And I'll show you what some of the answers are. So we have another intervention. And since those papers came out, the whole industry of seizure detectors has gone, has exploded. And so this is a terrific paper, 2016, when families come in and they want to know about seizure detection devices. It's all here. The bottom line, however, is there's zip data to suggest that any of these prevent SUDEP. 0. There's sensitivity and specificity for detecting seizures of different types, but what that has to do with SUDEP, we don't know. And there's been more than one case report of trained medical personnel, trying to resuscitate people who were going to die, and they died anyway. So it's not a one-to-one correlation. These things tend to be expensive, and they tend not to be covered by insurance companies. Oh, and this is a cartoon from Tobias Lodenkemper, and Toby is an expansive thinker, and so his thinking is, wow, the child has a watch on, a seizure is detected by the algorithm, it goes someplace to be stored for precision analysis, you get acute seizure treatment, you go to the hospital. Not quite there yet, but is it conceivable? Absolutely. And again, this is a table of SUDEP preventative strategies. Now, I'd like to end very quickly with a topic that I've been very interested in. If one believes that generalized tonic-clonic seizures, and by the way, other seizures of childhood, can cause death, and if one believes that intervention to stop those seizures can prevent death, then disclosure to families, one would think, is a good idea for an education piece, the public health education piece. And I believe that. How are we doing? And why talk about it? This is a hot button issue in neurology, by the by. And there's a whole issue about ethics, and comes down on the right to know, most eloquently written about by Nancy Collins, who also lives in the Chicago area. Understanding seizures, especially convulsive seizures, can do these bad things. It's a good thing to do. Patients can reduce their risk by medication adherence, lifestyle factors, and additional treatments like the ketogenic diet, VNS, epilepsy surgery, and the issue of empathy that I'll come back to. This is the slide that summarizes a lot of what Nancy wrote about, are the ethical basis for SUDEP disclosure. And these are the good things that you get by being honest with families and patients. So the question is, do people really want to talk about SUDEP? This is a big survey that was done. This is people with epilepsy, and this is caregivers of people with epilepsy. The number to remember is 70% of both populations want to be told regardless of risk. The patients, the families. This is another landmark study that was done in 2010 in Great Britain, looking at an outpatient clinic, asking families and doctors about this topic. Bottom line. First of all, 34% of parents already knew about it, so they get it from the internet, so you might as well tell them. 91% wanted SUDEP information. 67% wanted information at the time of diagnosis. And 72% said it had no adverse effects on their relationship with their kids. And there's a whole data set that I'm not showing you. So this is a very clear answer as to the vast majority want it, and they want it soon. What did their doctors do? The doctors that are taking care of these children? Well, not so good, in that a lot of them presented it to 63% with that intractable epilepsy, but only 20% was given to all the patients, the families. 20% versus 91%. Kind of a big difference. This is a study, a paper that I just put up because it's a summary across countries, and including pediatrics. How frequently was SUDEP discussed in comparison to suicidal ideation, driving restrictions, drowning, falling, and that kind of stuff? And it was discussed in the majority of patients, SUDEP, people with epilepsy, in 8%, 9%. Not so good. And this is, again, multiple countries. Why didn't you discuss it with your patients or your families? Well, This is the paternalistic attitude of doctors. I didn't want to raise concern in the patient, didn't want to raise concern in the family. You know, they're not at high risk. You can't do anything about it. So doctor thinking and patient family thinking are dramatically different. And I'll skip this. So what's best practice? Face-to-face disclosure by the healthcare provider. Explain risk and how to modify it. When do you do it? You know, obviously I'm giving you a talk through the lens of SUDEP. It's part of the regular education of people with families who are living with epilepsy. It's not the only thing, but in Great Britain, it's part of the national recommendation, the NICE guidelines, and there have been medical legal cases based on non-disclosure of actually teenage and young people that have died. So it's important. Are there exceptions? Sure. If you think it's going to do bad with your families due to whatever reasons, sometimes they're cultural reasons, usually they're wrong, by the way, use your judgment in the doctor-patient relationship. And so now we stratify into groups of patients. What's the high risk? If they have ongoing seizures, which means, it can mean 1 a year or 2 a year, that's intractable, especially if they're generalized tonic-clonic, especially tonic. If there's an etiology and they occur at night, they are high risk. So we agree on that. After 7 years, most of my colleagues agree on that. What's the purpose? Well, it's part of general education. The intent is compliance and consideration of other treatments. When do you do it? At the first office visit. How often do you do it? When you get concerns about compliance. I am not a very kind physician to my teenage male patients with intractable seizures, because they are as non-compliant as you get. And I'll say something subtle like, if you don't take your medication, you can die. You can die really soon. So do it. Not a very pleasant conversation. What about the low-risk group? Do you need to discuss it there? Well, yeah. Number one, they're going to know about it before they come to the office. The parents are already freaked out about it because they've read about it. So it can be reassurance. Try and get it done at the first visit, if time allows, not at the second visit. How often? You don't have to do it again unless there's a reason. And be aware of the non-asked questions. This is where you've given an erudite discussion, your child is at low risk, they've had a febrile seizure, everything's good, the parent looks back at you, 98% of the time it's the mom, and you clearly, they're not happy. Why aren't you happy? Because I'm afraid my child's going to die. So even if they don't ask, I believe one should offer that information. What is a low-risk syndrome? This is from a paper that's going to be published shortly. These are 3 children with benign epilepsy of childhood with Rolandic spikes, Beck's, the benignest epilepsy of childhood. 2 of them died. And they didn't have 50 seizures a year. This is a stunning kind of thing, because it brings to mind the question of, you know, in terms of disclosure, when we're having those discussions with this common epilepsy syndrome, we can no longer say your child's risk of dying is 0 to the best of my knowledge. It's not true. So this gets to the empathy part of the reason for disclosure. This is Chris Donalty. He's 21 years of age. He started having seizures. He was told by his doctors that SUDEP is rare, poorly understood. He died in college. He told his mom that he wasn't having seizures. Obviously I know his mother very well. And when she wrote about it, this was her letter to me. There is nothing worse than losing a child, no matter the cause or age. But a sudden death out of the blue, something that you were never told could happen, somehow makes it particularly cruel. All the unanswered questions, the what ifs. This is the #1 thing that parents and loved ones of people who have died from SUDEP will say. They never get over non-disclosure. And, you know, and I've now been doing this for probably 7 years and spent a lot of time with parents and loved ones, and it's a common theme. So you can never go backwards. So I discuss SUDEP with everybody. Just for you to know that although we're somewhat behind Great Britain, England, and Scotland in terms of guidelines, there is going to be a SUDEP guideline in April, American Academy of Neurology. It started in 2010. This is discussion for the reception. Just for you to know, there is intense research going on in the space of SUDEP, the SUDEP registry, very important. If you have patients who've died, please contact NASR. This is an NINDS project, Sudden Death in Youth. Center for SUDEP Research. The research funding for SUDEP in the last 5 years has been exponential. And Danny, that little boy that I introduced to you initially, his uncle, Tom Stanton, started the Danny Did Foundation. And they're out of Chicago. And it's been, I think, the most important family support group and action group for SUDEP in the United States. So with that, I want to thank you for your attention and have a good day. So I ran over a little bit, but I'd be happy to hang around for questions or whatever you like. Yes, sir.
I have a very simple question. You mentioned that the night supervision and sending the parents with oxygen at home. So do you send them with a water saturation monitor or something? Because it's very hard to.
So the question regards oxygen saturation monitors. My practice, which is pure anecdotal medicine, is I don't send oxygen monitors because the pulse oxes just tend to get funky at night, and the number of errors and awakenings of the family turns out not to work. We talk about what are the available seizure detection devices, and if they want to use that, and many of them are doing this already, by the way. They'll have baby monitors, they'll have motion, most of the ones that work are motion monitors, and those are the ones that they use.
Thank you for your talk. Once we learn to asking your comment, have you seen the trend over time? Has the trend of the SUDEP mortality has changed over time?
That's the billion-dollar question. How do you design a study to actually demonstrate that an intervention really works? That's been a huge issue in the field because it's a relatively rare event, and it would take a long time to know that. So the answer to the question is no, we haven't seen a trend, and because the field is just in the phase of case ascertainment. We're finding more and more. And so my guess is that what will happen is there'll be certain high-risk populations, like Dravet syndrome, that will have some kind of intervention, and because the frequency is higher, we'll be able to see a change in frequency.
Well, my thought was, if you look into the SUDEP over time, when the legal levels to later got introduced, they can impact on the surgery, what is the impact on the trend over time. So we can see that it's really just telling patient you may die, but you can't tell how you can prevent death. You know, that's the biggest question. I'm running the PAUSE study from the CDC from the self-management of epilepsy here. And many patients don't want to burn anything about their death. This is a very tricky situation when you cannot tell them how you can prevent it. And so I was looking into if there is any trend where you can share this information with patient. My other question here was, said that when there was in the surgery, if there is a zero seizure, the SUDEP depth is none.
In the original series, yeah.
In the original series. So when there is a no seizure, what is the likelihood of diagnosis of SUDEP infection when there is a zero seizure?
So part of the answer to that question is, you mean post surgery?
Post surgery, there is
Yeah.
no seizure.
Yeah, it's a couple of percent. It's not zero. And there's a literature that obviously didn't have time. There's a couple of literatures that we didn't have time to discuss. One of them is non-seizure related SUDEP, because there now been a number of cases recorded where there's been an electrical phenomenon and someone died and never had a seizure. So that's going to be a hard one. And then the other issue that you brought up is people don't want to hear about it. And so there's a study from Scotland. The first publication was, if I'm going to die, I'm going to die. And it was a qualitative research study looking at young adults. Most of the literature that you saw is for the good literature is in pediatrics. And so this was an interview series of young adults, and their qualitative answers, what are you going to do with this information, was sort of fatalistic. And that's why the title of the article is, if I'm going to die, I'm going to die. But I think that there's enough literature to say, if that's what you want to do with the information, okay. But as providers, we have very good information that if you have tonic-clonic seizures during sleep, your risk is much higher than if you don't. And here are ways to deal with it. Now, you may choose not to. The other thing that paper brought out was disclosure is not enough. The whole field in the last 5-7 years has been focused on just talking about it. And that was really the first paper to say, just talking about it doesn't do it, at least for that population. Was there a question in the back?
One question. During your talk, you had went through a lot of studies, and the only intervention that was truly noted to have any effect on SUDEP was patients who received oxygen, I forget where, maybe mentioned maybe in the ICU or high-risk patients. So why not send patients home? And it did show some substantial change in the rate of SUDEP.
Yeah.
So why send patients home with oxygen therapy at night who are high risk?
So it didn't exactly show that. What the study was the frequency, and actually was also duration, of the post-ictal generalized EEG suppression was shortened by oxygen administration, not death. But I think it's so what I said, and I think it's saying the same thing, was that if you have, if the risk factors add up, and you have people with documented post-ictal generalized EEG suppression of 30 seconds or more in duration, then those are very good people to send home with oxygen. Using that intervention for everybody wouldn't happen because, for all kinds of reasons, and then one has unintended consequences. So I think what we're trying to do, and what Dr. Van Voorhis was looking for, is trying to stratify populations based on risk and then intervention. I agree with you. Thank you very much.
So if people can stay a little longer, we have some food, some cheese, some
We're not going across the hall.
I think we can just stay here, if that's all right with you. I think it'd be a little easier, but,
Okay, excellent. I'm on service, so I have to go back to the unit. Yeah, this is
Still
very
on
good.
service?
Yeah, I still take 4 months, 3 to 4 months. One thing I'm just talking like a neonatologist.
Yeah.
That when you have auto deprivation post-ictal, that is central apnea.
Yep.
So, do you think with the they can give the oxygen, but they should stimulate the?
Yes.
That's what we do because it's just giving the oxygen.
Shake the baby.
Yeah, same to the post-ictal because there's central apnea, and central apnea, you have to wake that person like
Yeah. And so that's the whole question of even
just giving oxygen is not adequate.
and there's another literature
Let's eat something. I think.
based in stimulation. So yeah.
Good. Okay, so say hello to everybody.
I'll say hello. I will.
That's great. Yeah. Okay. Yeah.
I will.
I have to run, but I'm going to the adolescents. It was very nice meeting you, and we'll be in touch. I actually registered for the IHI. I was looking at courses.
Oh, you're fast. No one ever does fast.
Mary Lou Schmidt of Peds Hematology. Very welcome. And my nephew is 26 and he has autism. He had 120 seizures a year for 20-something years. And then vagal nerve stimulator, ketogenic diet, blah, 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 blah. And then
Yeah.
blah, blah, blah,
Yeah, I
blah,
know.
blah.
Yeah, I know.
And then he got on feet, and he is, in addition to his other meds, and he is miraculously seizure-free, which like, but anyways, I'm thinking about my sister, thinking, well, how many times would the doctor say he's at risk for suicide? Like, I mean,
Oh,
so I think,
So I think part of the kindness.
yes, that's what I'm thinking about, the kindness.
You said the reason why, because it was mentioned about this option, because you said da-da-da-da-da, which I interpret as means is tried on multiple medications, evaluated for surgery, at ketogenic diet, it was no stimulator. There's no reason to keep going at it because the purpose of trying to increase severity or whatever.
He has perfect, he's autistic and
And it's just doing it.
oh yeah. So
Yeah.
it seems like that's the one, if the purpose of informing is to prevent future guilt that somehow I couldn't prevent it or didn't know, or the purpose is compliance, those two things mean something. But, you know, at some point, but whether, it's interesting because she hasn't, we've never discussed it, but we've discussed it with her,
Don't be a doctor.
No.
They're
Just
sisters.
but I mean, we've talked about it.
Of course you
But the interesting thing is that I wonder if somebody said something way back when, 23. No.
Well, we're not.
We didn't know it
You
20.
see what you're talking about is a fifth standard deviation issue.